Swapnila. A very good morning to all of you. I'm Dr. Shruthi Mittal, and I welcome you all to our IC titled The Disc Dilemma. I would take this opportunity to welcome all the speakers and thank them to be a part of this IC. And I would also like to thank the organizing committee and the scientific committee for giving us this opportunity. So just to give you a gist of what to expect out of this IC, can I share my screen, Dr. Swapnila?
Go ahead.
Just for the correction, I am the hall coordinator. You all.
Okay.
Yes, you can please share your screen.
Okay.
This is IOPM. Then have your...
Just to guide you, you first have to.
Yeah. I know that. I'll do it. Just once.
Yeah, it's visible.
Yeah. To give you a gist of what to expect out of this IC, so we all know that the optic disc morphology can be affected by various congenital and acquired conditions. One of the most common acquired conditions is that we know of is glaucoma. And besides this, we also have a lot of neuro-ophthalmic conditions which may affect the optic disc morphology. Some of these neuro-ophthalmic conditions might actually present in the form of cupping, as seen in glaucoma. To name a few, it could be traumatic optic neuropathy or a compressive optic neuropathy or a methanol poisoning, or in some cases of ischemic optic neuropathy. So how do we differentiate in these various forms of optic neuropathy? This is what this IC is going to tell us. So it basically highlights the need to refocus on the basics. The importance of history and careful clinical evaluation cannot be understated. And now we have a large armamentarium of investigations to guide us in reaching a diagnosis. So we have a wonderful lineup of speakers to help us here. And without wasting further time, I would like to invite our first speaker, Dr. Prashant Srivastav. Dr. Prashant is a consultant at Netralayam and BBI Foundation at Kolkata. He has done a long-term fellowship in glaucoma and has also worked as a consultant at Shankar Netralaya. And he has been a speaker and at various conferences. And today he will be talking about the clinical evaluation of optic nerve head. Dr. Prashant, over to you. I'll stop sharing.
Yeah. So thank you so much, Dr. Shruthi, for your nice introduction. So I'll be sharing my screen. First of all, I would like to thank Dr. Shruthi for inviting me to this introduction instruction course, and also thankful to for AIOS scientific committee for accepting this instruction course. So I'm Dr. Prashant. I'll be talking about the clinical evaluation of optic nerve head in different conditions. So first of all, I have no financial interest. Am I audible, Shruthi?
Yes, you are.
So first of all, I have no financial interest in any of the equipments, instruments, or the procedure which is shown in my presentation. So when we are going to evaluate the disc, the first thing we have to consider that it is always better to evaluate a disc in a three-dimensional way. So stereoscopically, we have to use different lenses, a 90 diopter or 60 diopter lens or a 70 diopter lens, sit on slit lamp and examine the patient on slit lamp so that we get to see all the details of the optic disc. Sometimes when we examine the patient with a direct ophthalmoscope, we tend to miss certain findings, and certain findings when we miss, so we can miss a diagnosis of any disease. So optic disc is, what is optic disc? It's a visual part of optic nerve head which connects eyes to the brain, and the boundary of the optic disc is defined by the scleral canal. So in hypermetropes, the size of the scleral canal is smaller, whereas in myopes, the size of the canal is bigger. That is why the size of the optic disc varies from person to person. So normally it varies from 0.96 millimeter to 2.9 millimeter in different people. So a small disc and large disc, there are different variations we've seen. As a result, the physiological cup can also be small as 0.1 and can be as large as 0.8. So it is essential to first measure the size of the disc for a proper evaluation of optic nerve head. So how do we measure the size of the disc? So if you put if the patient is sitting in a slit lamp, we just put a thin beam of slit, and we can put it across the margin of the disc, which is margin of the scleral canal. So this is the margin of the disc, and we measure the size of this beam with the graticule which is present over the slit lamp in the upper portion of the slit lamp. And whatever is the reading, we have to correct it with the magnification factor. Now, different lenses, since they are magnifier, different lenses have different magnification factor. So if you're using a 60 diopter lens, it is 1, which is similar to the size. If you're using a 78 diopter lens, it is 1.1 times. You have to multiply 1.1 times. If you're using a 90 diopter lens, so you have to multiply 1.3 times. So that will give you an idea of actual size of the disc. Why correlation of size is so important? Because there are certain conditions which are present in small disc which mimics different conditions. So there can be confusion because of the size of the disc. Few of the conditions are optic nerve head Duchenne's, non-arteritic anterior ischemic neuropathy, and pseudo-papillary edema. Now, this is a picture of a Duchenne. Duchenne's are generally Duchenne's are collection of proteins and calcium in the optic nerve head, which gives the disc appearance of gives a little bumpy appearance. The disc will, if the Duchenne is present on the surface, it will appear like elevated disc and also a bumpy disc, and also the margins becomes indistinct. So it will mimic a condition called as papilledema. Now, papilledema is a condition in which there is high intracranial tension, and that is a high intracranial tension, that is a medical emergency that may require urgent lumbar puncture. So we have to be sure what is Duchenne and what is papilledema. A large disc, there are conditions which are present in large disc, like morning glory syndrome, which is a central excavation of the disc, which is because of premature closing of embryonic fissure, and congenital optic nerve pit. So these are the conditions which are present in the large disc. So after studying the size of the disc, next is shape of the disc. So shape of the disc normally can be vertically oval, is vertically oval. And the cup is horizontally oval. So if you see the disc, the shape is vertically oval and the cup is horizontally oval. If the cup becomes vertically oval, that means there is loss of neuroretinal rim over here and here. So generally in glaucoma, the first area to be affected is vertical, superior neuroretinal rim, inferior retinal rim. So the cup becomes vertical. So enlargement of the cup as well as shape of the cup is very suspicious of glaucoma and other diseases. Next point to note is the color of the optic disc. Now, color is very important in evaluation of optic nerve head, because color will give you a guide of different diseases. If you see a pallor like this in optic disc, which is very significant, so you should think of pathology which is other than glaucoma. Apart from cupping, you have to see the pallor. So you have to think of pathology other than glaucoma. And according to Greenfield criteria, if you have a pallor, significant pallor along with significant drop in vision, you must do neurological imaging to rule out other causes of disc pallor. So this is the disc picture which shows sectoral pallor here, and this area. So this is suggestive of a non-arthritic anti-ischemic neuropathy, and we must do neurological imaging in these such cases. Next area is optic cup. So the central pale area is called as optic cup. The central pale area is called optic cup. The central pale area is optic cup. This area doesn't have any axon, but they have glial tissue. It becomes more pale when there is enlarged cupping of the disc, because exposure to the underlying collagen fibers. When we are determining size of the cup, we have to see the contour of the vessel, not the actual size of the pallor. So generally, we have a tendency to see the area of paleness, but we have to see the area of the bending of the vessels. So in this picture, so generally we see the we feel that the cupping is from here to here, but actually we have to see this is the area of pale. This is the pale area, not the cup area. So actual cup area is determined by the area where vessels are actually bending. So we have to draw a contour line which actually determined by bending of vessels. Like in this picture, we see the pallor is going beyond the area of cupping. So drawing a contour line which actually determines and will be helpful to determine the actual area of the cupping. Next area of interest, and in fact, it is the area of most interest in the evaluation of many diseases, is the neuroretinal rim. It is a pink-orange area which is in between the margin of optic disc and the cup. As I said, the cup should be determined by the margin, the bending of the vessels. So this is the area which is important to us and which should be interesting to us, not the central cup. As in this donut, we are not interested in the central hole, we are interested in this chocolate. And similarly, in the disc, we have to evaluate the rim, not the cup. So normally the disc follows IS-N2 rule, which says that the inferior rim is generally thicker as compared to the superior, and then nasal, and the temporal is the thinner most area of the disc. The similar rule is followed. So most of the disc follow this IS-N2 rule. Some of the disc will not follow, and if there is no, if the disc is not following IS-N2 rule, we must think that there is some pathology in the eye. That could be glaucoma or something else. Like this, both the discs are. We can see both the pictures. The discs are very big, large discs, but these discs are following the IS-N2 rule. So inferior rim is thicker. So these can be a normal disc. Next point to note is asymmetry between two eyes, asymmetry of disc in between two eyes. So we have to look at the size of the disc, width of the neuroretinal rim, vessel course, and parapapillary atrophy. And if the cup size ratio, so normally 0.2 is a normal asymmetry which can be present in 96% of the patients, but if the different in asymmetry is more than 0.2, that could raise a suspicion of glaucoma. So more than 0.2 asymmetry, one should do for further follow-up and investigation to rule out glaucoma. Next area to study is retinal and nerve fiber layer. So nerve fiber layer are best visualized through dilated pupil, and they appear as white striations over the beyond the margin of the disc, and mostly they are visible in superior and inferior area because the nerve fiber layer is thicker at those areas. It is best appreciated by green light or red-free filter. So pattern of nerve fiber loss can be slit, wedge, or diffuse. So in this picture, we see there is inferior thinning of the disc along with a wedge-shaped defect, the wedge-shaped defect of the nerve fiber layer, which is highly suspicious of glaucoma. In the red-free image, we can see the defect is more clear here, which appears as a darker area. In this picture, in the disc fundus diagram, you can see diffuse area of RNFL defects. So multiple RNFL defects are present. So there is diffuse RNFL defect, which is also suggestive of glaucoma. If there is an RNFL defect, wedge-shaped RNFL defect, which is present in temporal, not in this picture, but if you find a defect which is temporal, that indicates an oblique insertion of optic disc, because temporal area you don't get normally a defect, wedge-shaped defect. So here we can see the normally diffuse RNFL defect. Again, in this picture. Next area is parapapillary atrophy or peripapillary atrophy. These are thinning and atrophy and degeneration of chorioretinal tissue because of ischemia and poor blood supply that exposes an underlying retinal pigmented epithelium, which gives tissue a moth-eaten appearance. So PPA differs, peripapillary atrophy differs from normal choroidal crescent that we find in myopia, and also inferior scleral crescent that we find in tilted optic disc. Now it has two zones. One, the peripheral zone is called zone alpha. The central zone is called zone beta. The peripheral zone is a peripheral crescent is characterized by irregularities of RPE because of atrophy of choriocapillaries. So they appear as a dark area here. Whereas zone beta is a complete absence of choriocapillary and RPE. So underlying sclera is visible here and choroid visible here. So that appears a more darker area, and it is more significant in case of glaucoma. And there are various studies where it's documented that zone beta is more prominent in cases of ocular hypertensive and normal tension glaucoma. Next finding is to examine the optic nerve head for to find any hemorrhage. So these hemorrhages are called Drans hemorrhage, which are present at the margin of the disc or one disc diameter away from the disc. It is basically occurs because of infarct of retinal nerve fiber layer, and it is mostly involved. If you find a hemorrhage like this, it could be a case of normal tension glaucoma or primary open angle glaucoma, which is progressing. in this two landmark trial by in the glaucoma, early manifest glaucoma trial and collaborative normal tension glaucoma trial, they have documented that presence of nerve hemorrhage or branch hemorrhage is highly suggestive of optic nerve progression, optic nerve glaucoma progression. Although they can also be present in NAIO and hypertensive and diabetic retinopathy. And at last, I would like to tell there are other certain subtle signs in glaucoma which is present in optic disc. These are not pathognomonic of glaucoma, but they are also present in glaucoma. So that again increases the evidence or to diagnose a case of glaucoma. They are laminar dot sign and bean pot cupping. Now, laminar dot sign is presence of prominent laminar dots because of thinning excessive cupping of the upper disc. And bean pot cupping and benotic sign is because of excessive excavation of the cup, the bending of vessel, because bending of blood vessel and excessive excavation of cup, it appears. And also because of loss of neurotenal rim, there may be nasalization of blood vessel and bearing of circumlinear vessels. So these are soft sign of glaucoma, which is not pathognomonic. So best is to examine the disc and examine the neural. This is my summary. So assessment of disc size and disc color is very important in evaluation of optic nerve effect for any of the disease. Cupping of the disc should not be decided by the color or pale area. It should be decided by the contour. Single evaluation of optic disc head is not sufficient, and also evaluation of CDI is not sufficient because observation may vary from person to person. And so for serial follow-up of a patient, optic disc photograph is the best tool to document and follow up. Thank you so much for your patient hearing.
Thank you, Dr. Prashant. That was a very informative talk indeed. And I know that you have to leave for the next session. Before going, I would like to ask you a question. So if there is a patient with a suspicious disc and a normal pressure, how do you proceed? Would you like right away start treatment for glaucoma, or would you like to investigate further or follow up the patient? How would you approach such
if a patient comes with a suspicious disc, that means it could be a large disc, it could be a disc which is thinning, and other parameters like IOP you're saying other things are normal. So first thing is to do a visual field test to evaluate whether the changes that you are noting on a slit lamp examination is corresponding to the field changes or not. If they are corresponding to field, suppose you are getting an inferior rim thinning and you get a superior defect in field defect, that means it is suggestive of glaucoma. In those cases, you can do the follow-up, and you can start treatment also. You can also take the help of other investigation like OCT to confirm your diagnosis. So if your first thing to do any suspicious disc, you can do a visual field analysis. And first thing to see is to correlate the finding, that the finding is correctly with your disc changes or not. If it is correlating, then you can further evaluate and start treatment.
And suppose you follow up the patient, how frequently would you follow up this patient if you're not starting treatment?
That again depends. If I'm following the patient, I'm not starting the treatment, that means the patient, the field of vision probably is normal. So in that case, they can be followed. If the pressure is normal, those cases, they can be followed up 6 months also. If there are other findings which present apart from field changes, like you get a normal disc with a disc hemorrhage and fields are normal, IOP is normal, those cases you can follow after 2 or 3 months. So if the patient is having an ongoing normal tension glaucoma pathogenesis, so a defect will appear after 2 or 3 months. So in those cases, you can follow the patient after 3 months. If there is this normal thing, no other specific finding, then you can follow the patient after 6 months.
Thank you.
Thank you so much. So I have to leave for another presentation. I would like to invite Dr. Shruthi for the next presentation. Dr. Shruthi has done a fellowship in pediatric and neuro-ophthalmology from Congenital, and she was a consultant at Congenital. Now she is practicing neuro-ophthalmology and pediatric ophthalmology at Mumbai. So welcome, Dr. Shruthi. Please share your slide. Yeah, go ahead.
Thank you, Dr. Prashant.
Thank you.
So I will be talking about various neuro-ophthalmic conditions mimicking glaucoma. I would like to start with this case of a 48-year-old male who presented to us with decreased vision in the left eye. His best corrected visual acuity on presentation was 6.6 in the right eye and 6.9 in the left eye. Pupils, color vision, and applanation tonometry were within normal limits. Gonioscopy and anterior segment was within normal limits. A disc evaluation showed normal size disc in both eyes, and in the right eye, the cup disc ratio was around 0.4 CDR with a healthy neuroretinal rim. Whereas in the left eye, it was around 0.5 with focal inferior rim thinning, and the rest of the neuroretinal rim appeared to be pink. Perimetry was done, and the right eye perimetry was within normal limits, whereas in the left eye, it showed a superior arcuate defect, which was correlating with the field, with the disc. So we followed up this patient with a DVT, which showed a normal IOP all through the day within normal limits. And so we decided to keep him under close follow-up. He was followed up every 3 months with intraocular pressure, disc, and field evaluation. And the fields continued to remain stable over a period of 2 years. Ultimately, he was diagnosed to have a probable inferior coloboma in the left eye and was kept under a close follow-up. This is another case which I have borrowed from this article by Chaudhary et al. And it tells us about a 65-year-old male who presented to the authors with a gradual progressive loss of vision. Elsewhere, he was noted to have cupping in both eyes and was also, and he had also undergone a trabeculectomy in the right eye. He presented with further decrease in vision to the authors, wherein his right eye vision was counting fingers 1 meter and left eye was 6'9". Color vision was decreased in the left eye, and there was RAPD in the right eye. Here his disc evaluation, like you can see, it showed a normal size disc in both eyes with a cup disc ratio of around 0.5 to 0.6 in both eyes with a fairly normal neuroretinal rim. But an important thing to note here is that with an almost normal looking disc, there was a marked decrease in vision in the right eye. So there is something which is not correlating here. The patient underwent perimetry and he was noted to have advanced field loss in the right eye. And in the left eye, there was a temporal hemianopia respecting the vertical field. The MRI was done and it showed a suprasellar lesion, and it was suggestive of craniopharyngioma. Further in this article, the authors discussed 6 cases. All of these cases had been diagnosed elsewhere to have primary open-angle glaucoma or NPG and had undergone either a trabeculectomy or was started on AGM. And all of these 6 patients were later diagnosed to have an intracranial SOL. So it is not common. It is not uncommon for us to come across such patients in the clinic where the intraocular pressure is normal and the disc is suspicious. So how do we avoid misdiagnosis in these cases? So let us start with the basics. What do we know about glaucoma? Currently, glaucoma is defined as a progressive optic neuropathy with characteristic structural changes, wherein the intraocular pressure may be either normal or high. So basically, intraocular pressure is not a defining feature of glaucoma. So if a patient presents with disc cupping and normal IOP, we reflexively diagnose such a patient with normal tension glaucoma. But an important thing to remember is that there are various non-glaucomatous causes of disc cupping, and the patient should be thoroughly evaluated before we label it as glaucoma. Going a little into the pathophysiology of cupping. So this is a cross-section of the optic disc. And here the dotted line shows the internal limiting membrane. The blue line shows the anterior laminar surface, and this orange area is the prelaminar area, which contains mainly the axons and the capillaries. And this scleral portion of the optic disc, it contains, besides the axons, it also contains capillaries and connective tissue like astrocytes. So in cases of prelaminar cupping, there is loss of axons, basically in the prelaminar portion, and this results in a backward shifting of the internal limiting membrane as seen here. And the cup that presents to us is a shallow cup, and there is pallor due to loss of axons. So this is usually seen in neuro-ophthalmic cases. Whereas in cases of glaucoma, there is extensive loss of connective tissue in the sclera, which results in the posterior shifting of the anterior laminar surface. And along with that, the internal limiting membrane also shifts posteriorly. So the cup is a deep cup due to the loss of connective tissue. This concept has also been used in a lot of studies, which have been measuring the distance from the Brooks membrane opening to the anterior laminar surface. And this distance has been found to be much more increased in cases of glaucoma. So besides glaucoma, the various other causes of disc cupping have been noted here. So this was a study by Rigo Diaz et al. And they have noted that around 15.8% of the cases of neuro-ophthalmic diseases could mimic glaucoma. And of these, the most common diagnoses were ischemic optic neuropathy, hereditary optic neuropathy, and compressive optic neuropathy. This was another study by Evelyn O'Neill et al. And they have noted that when a panel of experts was presented with various disc pictures, they could accurately reach a diagnosis based on the disc pictures alone only in 27% of cases of autosomal dominant optic atrophy and 16% cases of LHON. So what happens when we incorrectly diagnose these cases of neuro-ophthalmic diseases with glaucoma? It results in unnecessary treatment with AGM, resulting in a financial burden for the patient, or it may lead to a late or a misdiagnosis of a treatable intracranial tumor. So how do we differentiate these two entities? Clinical assessment, visual acuity and color vision in cases of glaucoma is usually preserved to the end stage, whereas in neuro-ophthalmic cases, there is early loss of both vision and color vision. In cases of glaucoma, ROPD is very rarely seen. Only in cases where the glaucoma is highly asymmetric would we note an RAPD, whereas in non-glaucoma cases, RAPD is often present. Optic disc in glaucoma shows very characteristic changes like vertical elongation of the cup, a deep cup, normal color of the NRR. There is focal loss of neuroretinal limb, also known as notching, positional change in vessels, also known as bionetting or splinter hemorrhages, a peripapillary beta zone, which is known to be associated with progression. And very important to note is that even in spite of having an advanced cupping, the vision might be normal or near normal. Whereas in non-glaucomatous cases, neuroretinal rim will appear pale, the cup will be shallow, there's no focal loss of NRR, no positional change of vessels, and the vision loss is often much greater than the cupping. Visual fields in glaucoma, like we all know, shows a characteristic progression. And in cases of neuro-ophthalmic diseases, we might either see a hemianopia or a centrocecal scotoma or an altitudinal defect. Important to note is that the fields always correlate with the disc in cases of glaucoma, whereas in neuro-ophthalmic cases, they may not correlate with cupping. Imaging in these cases has a limited role from my knowledge, although Dr. Rupak Roy will further highlight this. Basically, there's an overlap in structural measurement, and it may not be very useful in myopic patients due to the presence of artifacts. There have been a few papers on this, and this was one study which compared the optic nerve morphology in compressive and glaucomatous optic neuropathy, and they noted that there is no laminar remodeling detected in patients with compressive optic neuropathy. This was another paper of LHON where it was compared with NTG, and they noted that NTG patients had a much deeper cup compared to LHON patients. And when HRT was used, around 73% of the patients of LHON were wrongly diagnosed as glaucomatous. So how do we avoid misdiagnosing, and when do we take a decision that this patient needs to be neuroimaged? So here, this article tells us that when the glaucoma specialists, trained specialists were presented with these pictures and the perimetry findings of neuro-ophthalmic patients, they ended up misdiagnosing around 25% of these cases. And conversely, around 12% of glaucomatous neuropathies were misdiagnosed as neuro-ophthalmology. So even experts might sometimes find it difficult to differentiate these conditions. This was a paper by Ike Ahmed, wherein 6% of patients with NTG were found to have relevant intracranial compressive lesions, and all 4 of these had glaucomatous visual field defects. So is there a guideline? Yes, we have a guideline, and these are the current recommendations that we know of when we should take a decision to image a patient with a suspicious disc and normal pressure. So, but are these findings 100% specific for neuro-ophthalmic diseases? No, they are not. So this was a paper by Greenfield et al. And they have noted that the specificity of these signs like vertically aligned field defects, optic nerve pallor in excess of cupping, young age are only 77 to 93% specific for non-glaucomatous cupping. So coming back to this paper by Chaudhary et al., they have highlighted various factors that had probably led to the misdiagnosis of the cases that they had presented in their paper. Of these, the most common were that most of the physicians had failed to look at the pupils. Some of them had failed to look at the other optic disc features besides the cup disc ratio. Some of them did not further investigate. When they saw a cupping of the disc, they directly started the patient on treatment. And sometimes the fields and the acuity and the vision and the optic disc findings were not correlated. So the problem here is that we do not have one sign or one test which can accurately or 100% tell us that this patient is NTG or this patient is a neuro-ophthalmic disease. So what do we do in such cases? We would recommend an approach which is as follows. Always maintain a high index of suspicion. Do a good clinical evaluation, use a combination of differentiating features, and whenever something seems to be not fitting or the visual acuity and the fields do not follow a particular pattern on follow-up, do not hesitate to image. Thank you. I would like to call upon our next speaker, Dr. Subhranshu Singh Gupta. Dr. Subhranshu, he is a senior consultant at Center for Sight, Kolkata, and his area of specialty is medical retina, neuro-ophthalmology, and phaco-refractive surgeries. Dr. Subhranshu Singh Gupta.
Thank you, Dr. Shruthi, for the wonderful presentation and also providing me an opportunity to present in your IC. And a big thanks to the AIOS Scientific Committee and the Secretariat for organizing this wonderful online virtual conference. So I'll be speaking on congenital optic disc anomalies. So my screen is visible, Dr. Shruthi?
Yes, sir.
Yeah, visible.
Yeah, thank you. So now just let's touch upon the development of the eye, which starts at day 22 from an outpouching of the diencephalon. And what we have is, we should remember that the PAX6 is the master gene for the development of the eye. And this outpouching ultimately forms this optic stalk and this optic vesicle, which goes and envelops the lens vesicle subsequently. So the development of retina actually takes place from the two layers of the optic cup, whereas development of the optic nerve takes place from the optic stalk, which is basically the axons of the ganglion cells. So if we are just to summarize the development of the optic nerve, which happens around the 7th week, we have the ganglion cells of the retina, which develop axons, which form the optic nerve that converge and exit through the optic cup, exit the optic cup through the optic stalk. And the closure of the optic cup occurs inferiorly. So the inner layer of the optic stalk encroaches on the cavity of it until the inner and the outer layer fuse inferiorly and the cavity of the optic stalk disappears. So in a nutshell, the optic nerve is formed by the axons of the ganglion cells, covered by the meningeal layers and myelinated by the oligodendrocytes. So coming to the first optic nerve hypoplasia. It is the commonest cause of blindness in children in the Western world after cerebral damage and ROP, usually unilateral or bilateral. If it is bilateral, obviously it will be asymmetry presentation. Risk factors include a young maternal age, primiparity, and first trimester intrauterine insult. So what are the clinical features? So we get an abnormally small optic disc. The combined size of the small optic disc and the halo around it approximates the size of the normal disc. The blood vessels are usually of normal caliber. They might be tortuous, but in most cases, they enter or exit centrally. we might have decreased foveal reflex and decreased retinal fiber layer thickness. Now, coming to the double layer sign that is there. So in optic nerve hypoplasia, what we have is that the smaller optic nerve that is there is often surrounded by a whitish peripapillary ring of sclera and an outer concentric zone of ring of hypopigmentation. So the outer ring is actually the normal junction between the sclera and the lamina cribrosa, whereas the inner ring that is there, it denotes the extension of retina RP over the lamina cribrosa. Then there's another interesting point called the DM by DD ratio. The mean disc diameter is obviously the average of the vertical and horizontal diameters of the disc, whereas the disc macular distance is the perpendicular distance between the center of the disc and the macula. So a DM by DD ratio more than equal to 3, we can suspect optic nerve hypoplasia. And if it is more than equal to 4, then we very likely are looking at ONH. The visual acuity is also associated with this DM-DD ratio. If you look at the histopathology, well, in optic nerve hypoplasia, what we have is a subnormal number of axons that are there with normal mesenchymal elements and glial supporting tissue. So signs and symptoms, severe blindness, severe bilateral cases, blindness is there in early infancy with roving eye movements or nystagmus. The visual acuity might range from normal to severely impaired, but in normal cases, it usually remains stable throughout life unless associated with suprasellar tumor. And RAPD may be present. Bilateral cases, all we might end up getting is a sluggish light response. Localized visual field defects are very common in optic nerve hypoplasia. There's an entity called a superior segmental optic nerve hypoplasia or the topless disc syndrome, where we get this inferior hemifield disc like this. MRI, in isolated optic nerve hypoplasia, we will get a reduction in the diameter of the optic hyperplastic optic nerve. Here, in both the sides, we see that the diameter is reduced, and we might also have an absent septum pellucidum. Then there might be syndromic manifestations like we have the septo-optic dysplasia, which is a triad of optic nerve hypoplasia with absence of septum pellucidum and or partial or complete agenesis of corpus callosum along with pituitary dwarfism. And the other entity, early onset periventricular leukomalacia, may also be associated with optic nerve hypoplasia. Coming to the next entity, the morning glory disc anomaly, it's a congenital optic disc dysplasia in which a conical excavation of the posterior fundus includes the optic disc and it is filled with glial tissue. It's usually a unilateral sporadic condition, more common in females, and it is called so because it resembles the morning glory disc flower. Pathogenesis, many theories, but mainly it is the failure of the closure of the fetal fissure, and therefore it's a variant of, considered to be a variant of optic nerve coloboma. Clinical features, we have a funnel-shaped and enlarged dysplastic disc with white tissue and retinal vessels. They arise from the periphery in a spoke wheel pattern. Visual acuity is variable. It is usually low, may be associated with serous or egmatogenous retinal detachment and multiple intracranial disorders as well. Coming to the third entity, the optic disc coloboma might be unilateral or bilateral, may be associated with a PAX2 mutation. Pathogenesis, once again, is the incomplete or abnormal apposition of the proximal ends of the embryonic fissure. So clinically, we have a typically enlarged disc with sharply demarcated focal glistening bowl-shaped excavation of the optic disc. It occupies the lower part of the optic disc where actually the fusion of the fissure would have occurred. And the neuroretinal rim is usually absent inferiorly, but is identifiable superiorly. So this is how an optic disc coloboma would look like on FSA. Visual acuity would be variable, minimally affected in most cases. Associations might be associated with microphthalmus, various other colobomas of the eye, and systemic associations like the charge syndrome might be there. Now coming to the next entity, the optic nerve pit. It may be associated with juxtapapillary serous retinal detachment and may be bilateral in 10 to 15% of cases. So it's basically a herniation of the dysplastic retina into a collagen-lined pocket extending posteriorly into the subarachnoid space through a defect in the lamina cribrosa. So basically, the visual acuity usually depends on the amount of serous macular detachment. So this is basically an optic disc pit with serous macular detachment. Associations 1/3 to 2/3 present with these sort of detachments, which are commoner in 20 to 40 years of age. Now, what is important is that the fluid initially transits from the pit into the outer retina and then spreads either or both into the subretinal space or the inner retina. So we might have a variety of OCT findings, like we might have inner retinal fluid, outer retinal fluid, outer macular hole, and we might have subretinal fluid. So regarding the origin of fluid, there are various theories, like it might be CSF, it might be liquefied vitreous, or it might be leakage from choroidal vessels. Treatment, observation, laser photocoagulation, and gas tamponade with laser photocoagulation were earlier tried. But nowadays, most recent studies do indicate that the most viable treatment plan would be a PPV combined with laser photocoagulation and gas tamponade. The other entity that we can talk about is the megalopapilla, which is an abnormally large optic disc. But what is important is the visual acuity is mostly normal, no vertical notching, and the ganglion, the RNFL thinning might be there, but the ganglion cell complex thickness is always normal in megalopapilla. We might also come across congenital tilted disc syndromes of the Fuchs coloboma, wherein the superiotemporal optic disc is elevated and the inferonasal disc is distressed posteriorly, which results in an optic disc of oval appearance with its long axis obliquely oriented, may be associated with the torsional disc also. And field defects, this is very important. We do get bitemporal hemianopias in the tilted disc syndrome, which primarily involve the supratemporal quadrant. But what is most important, unlike trigeminal lesions, these do not strictly respect the vertical midline, and repeat testing with adequate refractive correction may actually eliminate the field defect. Then there might be less common entities like the congenital optic disc pigmentation. Optic disc drusen can be seen in up to 2% of the population, often bilateral and usually sporadic, might be buried, wherein we might confuse it with papilledema or exposed. RNFL thinning is common. And what is important is the diagnosis. You can do a fundus autofluorescence. You can actually do an ultrasound where in low-gain settings, we can pick up the calcification of the optic nerve. And the OCT, which Dr. Roy will be speaking in details, is also a very important marker to study the serial progression. It might be associated with a variety of diseases like retinitis pigmentosa, complications of optic nerve drusen, rarer, but you might have a juxtapapillary PNVA, might have hemorrhages, AION. Then there are other entities like, for example, you might have myelinated nerve fibers, you might have Buckminster's papillae, you might have optic disc aplasia with these various pigmentary changes and various degrees of aplasia of the retinal vasculature as well. Finally, my last slide, rehabilitation of a child with visual impairment due to congenital optic nerve anomalies. This is actually very important. Optimizing visual function, correcting the refractive error at the earliest and patching if there is amblyopia, working with the parents, breaking the news to them, making them understand the gravity of the situation, measuring the visual function and working within visual limits. Language framework required to compensate for reduced vision should be established. Low vision aids may be considered, ensuring that impaired vision does not lead to developmental delay, and of course, provide sources of information for the parents and children. Thank you very much.
Thank you, Dr. Subhranshu. That was an excellent presentation and extremely insightful. I would now like to invite Dr. Rupak Roy. I think he needs no introduction. He is a vitreoretina surgeon at Shankar Nethralaya, Kolkata, and he has done a lot of work on OCT imaging in various conditions. And today he will be talking to us about imaging of the disc and RNFL. Dr. Rupak Roy, over to you.
Yeah, I'm sharing my slides. Just give me 1 second. So is my slide visible?
Yes, sir.
Yeah, thank you, Dr. Shruthi, for kindly inviting me in this course, and thank you, AIOS. So I'll be speaking on disc imaging in neuro-ophthalmology diseases. So if you see the OCT, there's a lot of revolution in the OCT technology. We have evolved from being a time domain to a spectral domain now, which is a much greater resolution as compared to a time domain OCT. So OCT applications in neuro-ophthalmology are basically in imaging of RNFL, the GCC, and also we have applications of multicolor in neuro-ophthalmology and OCT angiography. So RNFL is unmyelinated axons of forming the optic nerve. It is a window to brain disease. Axonal loss is a promising biomarker of multiple sclerosis, and OCT is the most sensitive technique to evaluate RNFL changes. So if you see the cross section, this is how the layers stack up in our OCT. This is the ganglion cell layer, and this is the retinal fiber layer here. So this is a 30-year-old woman with an optic neuritis accident. So if you see the spectralis and the serous, both shows a bilateral RNFL thinning, damage predominance in the temporal quadrant. So here we see the efficacy of imaging. The patient has RNFL thinning even when the patient has a visual acuity of 20 by 20 and a half visual field, which is normal. Coming to the GCL and the IPL complex, GCC thinning is the early biomarker for neurodegeneration. It is an earlier biomarker for neurodegeneration as compared to RNFL. GCL correlates better with visual dysfunction, disability, and MRI than RNFL thickness. So GCL plus IPL has a higher correlation with perimetry. It's predictive of progression and predicts visual recovery post-surgery. So this is a 22-year-old man who has a sudden painful loss of vision, presented to us in 2013 post-IVMP and oral steroids. The visual acuity in the right eye was 6 by 6 in the right eye, in the left eye is 1 by 60. And visual acuity is 6 by 6 in the right eye. The old document showed visual acuity of 1 by 60 in the left eye. When he presented, the visual acuity was 6 by 9. The color vision was 16 by 16, and OS it was diminished with 14 by 16. MRI shows brain periventricular plaques. And if you see the serial RNFL and the GCC analysis, we can see that OCT can detect subclinical axonal loss in eyes with normal visual fields and normal visual acuity, as is seen in the progression of these charts. Microcystic macular edema is another interesting finding in cases of multiple sclerosis. Microcystic macular edema is notably seen in the inner nuclear layers, usually in the parafoveal fovea sparing. When optic neuritis due to any reason, including MS, this is because the retrograde degeneration of the inner nuclear layers also can be seen in intermediate uveitis and phenylomyard side effect. Now, this is a case of papillary edema where the finding is acutely thickened retinal fiber layers, whereas in chronic cases, you'll have RNFL thinning in optic atrophy. GCL plus IPL analysis can give you early detection of the neuronal loss, and GCL is a good prognostic indicator. Now, this is a 37-year-old female who used sudden dimness of vision for 1 month, severe headache, vomiting, binocular double vision, diagnosed elsewhere with cerebral venous thrombosis, MRV, no flow in left transverse sinus, treatment with cerebral anti-edema and drugs and warfarin. As you can see, there is a progression of the, am I audible? Yeah, this is the patient. This is the patient who's at present in the picture is like this: 6/9 in the right eye, 6/36 in the left eye, and final follow-up is 6/6 and 6/12. And you can see the progression of the GCL and the IPL thickening, as can be seen in the charts. So multicolored confocal imaging is another interesting imaging modality for neuro-ophthalmic disorders. It generally gives you information about 3 layers, 3 wavelengths. That is the infrared. This is the infrared channel. This is the green channel, and this is the blue channel. And this is the composite multicolored image. Now it is very useful in differentiating true disc edema from false disc edema. So this is a case of optic nerve head drusen, where you see there is a greenish discoloration around the disc, but the margins are absolutely fine and well demarcated. There is no spillover of this green lesion into the adjacent orangish retina. On the other hand, if you can see, this is a case of a disc edema. So you can see there is true disc edema, where you see the contour of the greenish elevation is irregular, and there is extension of this greenish margin into the adjacent retina. So, so greenish discoloration of MC images has been observed due to result from any type of thickening or elevation. But if it's a true pseudo disc edema like an optic nerve head drusen, the thickening will be more regular and well defined without any ragged margins. On the other hand, if it's a true disc edema, you will see it as a ragged margin. This is again comparing our true disc edema with optic nerve head drusen. You see this is not extending beyond the optic nerve head margins. Also, it has some role. There is an entity known as occult disc, where you can see this is a clinical color fundus photograph where you are not able to see the disc, but you see macular edema in the macular region. When you do multicolored imaging, you are able to see the optic disc bit here, which is not seen in the conventional color fundus photograph. So this is one other application of the multicolored imaging. OCT angiography evaluates microvascular abnormalities, vascularity of the radial peripapillary network, metabolic activity, number and vitality of the nerve fibers present, measures peripapillary capillary density and flow index. OCT evaluates flows in a precise and longitudinal manner. So this is a patient of disc edema, where you can see there is a flow void here around the optic disc region. So this is a case of NAION. This kind of flow voids in the peripapillary region is common in cases of NAION. So to conclude, measure and detect RNFL GCL loss in optic neuritis. It helps in prognosticate vision and field changes pre-op in papilledema and optic neuritis. Multicolored imaging to differentiate between true and pseudo disc edema, and OCTA is emerging as a new tool. I acknowledge Dr. Sujata Guha for her help in this presentation. Thank you very much.
Thank you, Dr. Rupak, for your talk. We will take any questions if there are any for the speakers. Dr. Subhranshu, I have one question for you. Are you still there, Dr. Subhranshu?
Yeah, I'm there.
I wanted to ask you, do you routinely use OCT in your disc, your disc diseases like in neuro-ophthalmology or in glaucoma? Do you often use OCT?
See, as far as the neuro-ophthalmology cases are concerned, sometimes I use the RNFL as to measure the serial progression. In the sense that suppose it's something like optic neuritis, we have a certain RNFL thickness, and then you cannot put the patient on MRIs every 6 months or 1 year, but at least if there's a sudden decrease in the RNFL thickness, also diminution of vision, then in these situations we can always ask the patient to go back for neuroimaging that way. Yeah, and then of course actually in cases of this optic nerve head drusen, when we are not sure, we do not have this multimodal color imaging as Dr. Rupak Roy had said, but we in a normal spectral domain OCT, we can actually image the optic nerve head and actually pick up these calcified drusen bodies, and then we can actually serially follow up the patient in case as when required. So yeah, I do use. What is the experience in your case, Dr. Shruthi?
So yeah, we also use it very sparingly actually. maybe in cases of IIH, where you want to serially evaluate the RNFL thickness and look at the edema, whether it is increasing or decreasing, along with, but it is always along with an adjunct like an HVF and obviously with the clinical evaluation. Dr. Rupak, I had one question for you. If Dr. Rupak?
Yes, please.
Yes. So would you, have you used multimodal imaging in cases of glaucoma, or have you for cases of glaucoma ever?
So I have used multicolor imaging in cases of glaucoma. It is a very sensitive tool to detect retinal nerve fiber defects around the disc. Yes, we have published a paper on this in IGO, where it is more sensitive than color fundus photograph in picking up RNFL defects around the disc. Yes. So normally the multicolor image will have a greenish hue. That is because of the that hue comes from the nerve fiber layer. And if you see that localized area of this loss of hue, you can imagine, or those are the points where the RNFL loss is there.
So these multimodal imagings can be done on a regular Spectralis OCT, or does it need some
Spectralis? No, Spectralis machine is Spectralis with a multicolor module can do this.
I think that was a nice session. Dr. Subhranshu, would you like to give a
just one question for Dr. Rupak, since he's here. With your huge experience of managing these cases with optic nerve PIT, so have you had, what is your experience with only photocoagulation vis-a-vis observation, vis-a-vis actually going in for a PPV with tamponade?
So in a case with optic PIT, optic nerve head PIT with macular edema or fluid in the macular area, the first step will be to do a spectral domain OCT, which goes through the disc and the adjacent retina to look for communication between the PIT and the retina. So this is the first step. So if you find there is no communication between the PIT and the retina, you tend to observe the case, because it is expected that the fluid will resolve over a course of time. If there is a communication that you can detect between the retina and the PIT, the first line of therapy would be to doing a laser photocoagulation, a red or a diode laser, very light burns around the area of the PIT, and observe patient for 2 to 3 months. If the patient has no appreciable improvement, then you go to the next step. In some cases, obviously, if you do OCT and if you see there is a vitreomacular traction or sometimes some sort of fibrous tissue over the disc or the macular region, in a case of optic disc PIT, you tend to go in early and do surgery early. And also in cases which has got a communication between the retina and the PIT and it is not resolving after doing laser photocoagulation, we go for vitrectomy with interlimiting membrane peopling. So first step is looking OCT to look for a communication. If no communication, observe. If communication, can do laser as a first point, and if it is not resolving, do surgery. And in patients with optic PIT where you see visible vitreomacular traction or areas of fibrous tissue over the disc, go ahead with surgery at the first point.
Thank you so much, sir. So this was quite an informative session for all of us who presented and all those who attended. Dr. Prashant, he was wonderful in showing us how to evaluate the optic nerve head clinically. Then we have Dr. Shruthi, who brought out very wonderful cases where neuro-ophthalmic conditions were mimicking those with glaucoma. I presented on congenital optic nerve disc anomalies. And of course, Dr. Rupak, the icing on the cake, the wonderful images, the multimodal imaging and stuff, and his wonderful paper that we all have gone through. So Dr. Shruthi, thank you very much for putting together such a wonderful session. And of course, the AIOS for carrying on this show seamlessly. Thank you. Thank you all.
Thank you. Thank you, Dr. Subhranshu. Thank you, Dr. Rupak, for being a part of this IC. And I think we'll close here.